Um, Good morning, ladies and gentlemen, my dear colleague. Welcome to the APSC cloud webinar. Today's topic will be cutting-edge treatment for pediatric arrhythmias. I'm honored to co-chair with Professor Insu Bei to chair this meeting. We will have 5 speakers who will deliver talks to cover the scope of pediatric arrhythmia and the new treatment for arrhythmias. As you may know, arrhythmia may occur from prenatal stage in neonates, in children in adolescence and adulthood, even in those aged adult congenital heart disease. And I think this spectrum is even wider than that in adults. So I think the topic will cover a very fantastic area, and we would like to share all the complexity and novelty to all the audience. And now I would like to introduce our first speaker, Professor Swee KWOK. And Professor KWOK is the pioneer and expert in pediatric cardiology. He is professor of cardiology in Singapore National University, and now he also the head of medical affairs in the hospital. I know her for many years, and I really admire his vision on in managing all the problems in pediatric cardiac children. And it's our pleasure and honor to invite him to deliver the talk, The Scope of Pediatric Arrhythmia. Dr. KWOK, please.
Thank you very much, Hwan and the team. Thank you for inviting me. It's good to see all of you again today on this webinar. I'm going to share my screen now. Are you able to see?
Yes, no problem.
Okay.
Thank you very much. So today the topic of my talk is on the scope of pediatric arrhythmias. And I'm very grateful to Professor Wu for setting the stage for this. I'm just going to go on to the next slide, which covers all that we need to know, or at least is a short summary of the pediatric arrhythmias, not very unlike adult arrhythmias, but also bearing in mind what Professor Wu had said, and I'll just briefly mention it later on in my talk, that it starts from the prenatal all the way up to kids, pediatrics, and then on to the adults. Broadly speaking, we can classify pediatric arrhythmias into 2 big groups, the tachyarrhythmias and the bradyarrhythmias. And again, for the tachyarrhythmias, we can subclassify them into 2 categories, the atrial and the ventricular rhythm disorders. And for the bradyarrhythmias, it would be the heart blocks. That in itself summarizes the broad spectrum of pediatric arrhythmias. Of course, this is a simplified version, and we will hear from the experts a little bit later about the nuances and the treatment of some of these conditions. We can broadly look at the mechanisms of arrhythmias into 2 big groups, those that have problems with impulse generation, either it's too rapid or too slow, and those that arise because of conduction of the impulse in a different way. So if there is a block, it leads to the heart block that we talk about in the bradyarrhythmias group. And if there is a problem with a re-entrant, this is the mechanism for many of the tachyarrhythmias that we would allude to later. We all know that the SA node is the usual normal pacemaker of the heart, and from the SA node, the impulse is then transmitted to the AV node, to the bundle, and then to the right and left bundles and to the rest of the heart. But should any of the heart muscle have a faster rate than the SA node, then that becomes the enhanced focus of action, and it takes over as the normal pacemaker, and it leads to an automatic tachycardia, which is the mechanism for many of those that are shown on the slide, EAT and some ventricular forms of ventricular tachycardia. One of the more common mechanisms is the re-entrant tachycardia that I'm sure many of us would be familiar with. And for this to happen, that there are three important prerequisites: the concept of an accessory pathway, or extra pathway in addition to the normal conduction pathway, and the fact that there is in this accessory pathway a unidirectional flow and an anterograde block. And the third important prerequisite is the fact that there is differential conduction velocity in the pathway, and this allows, if you can see the diagram below, for the impulse to go round and round like a dog chasing its own tail, leading on to the tachycardia. In terms of what we more commonly seen as pediatric cardiologists would be children or teenagers complaining of palpitations, and that sensation of palpitations can well result from either atrial ectopic or ventricular ectopic. In PACs, it's more common in children. PVC is more common in older teenagers and adolescents. You can see here that we have a PAC where the QRS complex is similar to the preceding and the one following, whereas the ventricular ectopic results in a more bizarre and widened QRS morphology. So again, in a very common complaint that we see in the clinic setting where children come to us complaining of palpitations, it's important to identify the frequency and whether this is of unifocal or multifocal type of PACs and or PVCs, and the symptoms that accompany these palpitations. For example, if a patient complains of syncope, and we know then that there is a red flag because this may indicate hemodynamic compromise and we would be a bit more aggressive in the management. It is also important for us to elicit the presence of underlying medical problems, existing cardiac problems. It could be a post-operative condition, and also looking into the medications that this patient may be on, and also family history of sudden events. In themselves, palpitations or ectopic beats causing palpitations are usually benign, but clearly they can be a marker of underlying pathology, or in themselves be an initiation of the re-entry that we talked about in susceptible patients with accessory conduction paths. The diagnosis of pediatric arrhythmias is no different from adults, and this is the usual armamentarium that we have in order for us, the basic ones. And if we were to jump into SVT, which is one of the most common rhythm disorders that we see in kids, it's again a rapid heart rate arising from atrial, AV junction or the accessory pathway. And you can see here that we have many examples that would lead to this common term called supraventricular tachycardia, EAT, where there's an abnormal automatic focus that I talked about earlier on, multifocal atrial tachycardia with 3 or more P morphologies, JET, which we not uncommonly see after some post-op cardiac op patients, re-entrant tachycardia, and the whole series that leads to SVT, as well as the other atrial dysrhythmias. Ventricular tachyarrhythmias, as we know, tend to be a lot more serious in terms of hemodynamic compromise, and the very fact that it is associated with, it tends to be more closely associated with underlying pathology such as a channelopathy, a cardiomyopathy and also may result from or result in abnormal myocardium and reduced heart function. Some of the principles of treatment in pediatric arrhythmias, and I'm sure that our expert speakers that follow would talk more about particular conditions and more sophisticated treatment modalities, but I thought that it's important for us to just look at broad options in the principles of treatment. It could be conservative if we think that the rhythm is a benign one or is very infrequently encountered in the child. Medical management in terms of pharmacologic treatment in the acute abortion of the rhythm disorder or in the chronic management of patients. And in more recent times, again, groups have done electrophysiologic study and ablation, and this clearly is the way to go in terms of more definitive treatment for some of the more recalcitrant or difficult malignant type rhythm disorders. And then pacemakers, pediatric pacemakers for patients who have got bradyarrhythmias, ICD, a combination of the above. And again, it is important in our practice because we do manage patients who have got structural heart disease and who go for surgery in addressing residual post-op heart defects. One good example are patients who have had surgery for tetralogy of Fallot with residual lesions, which may include right ventricle outflow, tract obstruction, free pulmonary incompetence and regurgitation, dilated right heart, residual VSDs. And again, in treating these patients who may present with ventricular tachyarrhythmias, it's important for us to address these residual post-operative heart defects. Just a quick word on fetal tachyarrhythmias. Again, the advances in obstetric care, advances in our ability to do fetal echoes have led to early detection. And this may be associated with complications such as high drops, and that there is a lot now on successful treatment of fetal tachyarrhythmias, such as fetal SVT with medications. And I think that, again, importantly, it's about when, if there are complications, if the patient is in, if the fetus is in congestive heart failure, if there's high drops, when to deliver the kid, other complications with premature lungs, prematurity, and a balance is needed to be struck in between treatment of the heart and prematurity, and the fact that babies with a smaller age tend to have present bigger problems in terms of definitive management with pacemaker insertion. Swinging on to the other extreme, which we should also be mindful of, but sometimes can be forgotten as more focus is placed on the tachyarrhythmias are the bradyarrhythmias. And here we talk about the different types of heart block and also the sixth sinus rhythm. In first degree heart block, again, a prolonged PR interval from slow conduction velocity. And again, many of these patients tolerate this well. They do not require treatment, but if there is an underlying problem, it is also important for us to ascertain that and to treat that bit. For second degree heart block, we know that is categorized into the Mobitz type 1, the Banki-Bach phenomenon, as you can see in the strip below, and the type 2 heart block, which is a little bit more high grade. Moving on to the third degree heart block or the complete AV dissociation, again, bearing in mind that there are congenital causes and acquired causes. Congenital causes, maternal antibodies such as the anti-Ro and La antibodies may lead to problems with the fetus. And I alluded to that about prematurity and the need to tackle this bit of it. Again, we're not talking now about tachyarrhythmias, the fetal SVT, but fetal heart blocks, and perhaps that we have to deal with this and manage this together in consultation with the obstetrician, with the neonatologist, and this bit of with the surgical team as well. In symptomatic patients, they will need a pacemaker, and even in those who are asymptomatic, there is a risk of sudden event in those who are not treated. For the acquired causes of third-degree heart block, again, it may be due to a complication of surgery for heart defects, interventions, device insertions, and this may be temporary, which would mean that there is good outcome. It may resolve in a few weeks, or it could be permanent, in which case then we need to consider the pacemaker insertion. And there are the rarer causes, which would include inflammation, infections, and other causes of third-degree heart block. And then the sinus node dysfunction or the sixth sinus rhythm, characterized by episodes of bradycardia, slow P wave rate, and the escape rhythm. And within itself, sometimes there is atrial re-entry leading to episodes of bradycardia, tachycardia, as well as pauses. Pediatric pacemaker, just a quick word again, in the pediatric age group, it's again the nuances of size, weight, device, equipment, technique, whether or not we put in an epicardial lead in a very young preterm baby versus endocardial leads in a child. We need to be mindful that there's going to be future growth, and clearly there is the expertise that is required for the younger patients. Not forgetting that there may be coexisting structural heart defects, post-operative complications, such as that one that I alluded to earlier on in the talk, and the inherent risks of congenital heart disease predisposing to rhythm type disorders. ICDs, implantable cardiac defibrillators with sensing lead for ventricular rate, the ability to deliver a shock when the VT or VF is detected, and it also has a pacing function with indications for ventricular arrhythmias that may be malignant or potentially putting the patient's life at risk. So in conclusion, the scope of pediatric arrhythmias is indeed diverse and large. And we do know that with increased awareness, we are able to now better map how these rhythm disorders can impact hemodynamics of the child. And there have been major strides and advances in the management, including adopting what we have known in adult practice, EP, ablation, pacemaker therapy, but of course bearing in mind pediatric considerations of size, weight, and safety profile of medicines and interventions. There is clearly an interplay between structural heart defects and operative complications in the etiology and the management of arrhythmias. And it is important for us to bear in mind that many of these rhythm disorders can have a profound impact on the activities of the child, the quality of the life of the child. And this is something that I don't have time to talk very much about, but it is something that as pediatric cardiologists, we should be absolutely mindful of and to take into consideration all of these in the complete and holistic management of the child and the family with a pediatric rhythm disorder. Thank you very much for your kind attention. Over back to you, Hwan.
Wonderful talk. It's really a very concise, and very clear. And I think everybody knows the scope of pediatric arrhythmia, and we now know what kind of question we need to face. And so we will leave the other question after the third talk. And I'm going to introduce the second speaker. The second speaker will be Professor Sheuun-Nan. He is currently Professor of Pediatrics in National Taiwan University Hospital, National Taiwan University Children's Hospital. And he has been dedicated to the application of new technology in children for many years. And he had done a lot of in-depth research on the new advancement or new treatment for pediatric arrhythmia. we are so happy that we can invite him to deliver a talk of novel transcatheter ablation modality for pediatric arrhythmia. Professor Chu, please.
Thank you for the chairman's introduction. Dr. Guo has told about the scope of pediatric arrhythmia, and as we know, one of the important tools to treat this arrhythmia is the catheter ablation, and there are many advances of technology about the catheter ablation. So I will talk about the novel transcatheter ablation modality for pediatric arrhythmia. Traditionally, we use the X-ray guidance our catheter location for the APSC and the pediatric arrhythmia, and we use the radio frequency as the energy source to treat this arrhythmia. However, the advance of the technology has however, the new technology can increase the safety and also increase the safety of the catheter ablation, also increase the efficacy of the treatment of the pediatric arrhythmia. And there are many new technology. Here I will talk about the 4 new technology about the treatment of the pediatric arrhythmia. This includes the non-fluoroscopy mapping and the ablation. Second, the cryoablation for perinodal arrhythmia substrate. The third, the ultra-high density mapping for complex arrhythmia. And also for the contact force catheter with half partial duration IF ablation. So let's see the non-fluoroscopy use in pediatric arrhythmia ablation. Traditionally use the X-ray guidance. The fluoroscopy time range around 10 to 60 minutes, and for the complex arrhythmia, the fluoroscopy time may be even higher. The principle of radiation exposure has changed from the as low as reasonably practical to achievable, which emphasizes the need to achieve. And for small children, the radiation adverse effect is even higher. This is an illustration for the medical radiation. For the EPS and ablation, the radiation exposure dose is around 4 to 20 millisieverts. It's equal to 200 to 1000 chest X-ray field. So it is not a low radiation. And this is a study from the European Heart Journal. When we use a new technology, this is a minimal fluoroscopy approach. The lifetime achievable cancer risk can decrease around 30 times in male and 40 times in female. So it is that reduction of radiation harmful effect. So this is a live video of our EPS now, and we can see the EP doctor advance the catheter, and all of the staff and our fellow and also the nurse didn't wear that apron or this glass anymore. So how can we use this non-fluoroscopy approach? So first we will introduce a 5-inch coronary sinus catheter. It is soft and relatively safe. When we advance the catheter, the geometry of the IVC root and also can be seen very clear. And when we introduce into a heart, we can see the intracardiac electrical signal. So here we can mark the IVC and the SDC, and we then try to introduce the right ventricle and then rotate the catheter. It will jump into a coronary sinus. So it is not difficult. And when we introduce the second catheter, because the geometry was already be created, so we can advance the catheter very safe through the previous route of the catheter. So we introduce the catheter from another femoral vein and then go through this geometry. Okay. So the use of this 3D mapping system can not only guide our catheter location, but we also can use this approach to perform a simple activation map. That means we can know where is the earliest earliest V site or the earliest retrograde A wave site. So we can target we can find our target more easily. And this is a 7 kilogram young infant. She had a frequent arrhythmia attack and refractory to a medical control. So we have to perform this operation at 7 kilogram. And with this 3D approach, we can target this site very easily. This is a brief static about the non-fluoroscopy and the conventional operation, the comparison. We can see when we use the non-fluoroscopy method since 2017, the fluoroscopy time can decrease dramatically from mean 25 minutes to 0 minutes. And 91% can achieve zero fluoroscopy mapping. The success rate was equal at around 98% between these two groups. And the procedure time didn't show significant difference in these two groups. So we can know this new 3D mapping system can reduce the radiation dose for patients and for doctors, and also reduce the doctor burden. We don't need the F1 and don't need this gas anymore. And the 3D mapping system can help us guide the operation substrate, and it can also annotate our previous operation site, which is also helpful for our catheter operation. However, there is still some limitation. The technical training the learning curve may be around 10 cases. However, for the transeptal approach, the cryo balloon operation or the intracardiac lead, it cannot be seen by the 3D mapping system. So in this situation, especially for some complex congenital heart disease, the eyes assistance is necessary. Second, I will talk about the cryo operation used in pediatric arrhythmia. So one of the most important complication or the nightmare of the EP doctor is the AV block during the catheter operation. Although the success rate of the catheter operation cannot achieve more than 95%, however, the complication is still cannot be avoided completely. For the AVNRT, the complete AV block rate is around 1 to 2%, and for the septal substrate of AVRT, it can be around 1 to 10%. For the congenital heart disease, because of the depressed AV node, the complication may be even higher. However, we have a new technology now. Traditionally, we use the radio frequency. It is a heat to heat the substrate, and for now we have the ice to frozen the substrate. We can use the ice to decrease the temperature to around minus 85 degrees Celsius, and it can cause cell necrosis and apoptosis. And we can perform this new operation. And this ice technique, compared to the previous ice technique, we can see the lesion size is a little smaller and less damage to the peripheral tissue, and also we preserve the vessel. So the nodal artery injury and dead AV block is rare in this situation. And we have less thrombus compared to the radio frequency approach. In clinical practice, we can perform the cryo mapping first. We will decrease the temperature to around minus 30 degrees Celsius. And we can see if the normal AV conduction will be impaired. If the AV node conduction is normal, we can shift to the cryo operation to decrease the temperature further to around minus 75 to minus 80 degrees Celsius. And it will cause permanent injury of the arrhythmia substrate. So this stepwise increased cranial energy can decrease the risk of AV block. After the introduction of the cryo operation, there are many studies to compare the cryo operation and the radio frequency. This is a clinical trial in 2010. We can see the success rate is still not significant difference, although a total in the cryo-ablation group. However, the death recurrence rate is higher in the cryo-ablation, and it's around 2 times the recurrence rate. In 2016, the consensus of the PACE and the HI's expert consensus show the AVNRT saturation using the cryoablation is around 90% and recurrence rate is around 9%. For a partition and pathway, the saturation is also 90% and the recurrence rate is around 12 to 40%. However, the advance of the technology and the more knowledge about the cryoablation, we have increased the saturation and decreased the recurrence rate now. Even for the higher recurrence rate in the cryoablation, compared to the radio frequency, there will be no AV block. And for the radio frequency, there will be minimum at least around 1% of AV block risk. For a patient of AV block, the patient will have worsened quality of life. He had to change the pacemaker generator every 10 years. And sometimes the lead will be broken and the lead extraction is necessary and the lead infection cannot be avoided completely. So the patient will have the dismal life after the AV block. And for the cryoablation, even for the patient have a recurrence of arrhythmia, what we have to do is another ablation, so it will not cause this quality of life and pacemaker implantation complication. So in the current guideline, in the expert consensus, they say in the catheter ablation of pediatric arrhythmia, it is reasonable that cryoablation should be available as an option for the pediatric arrhythmia ablation for AVNRT and for the septal substrate. In our initial experience, in initial 2 years experience, we have a success rate around 98% and the recurrence rate around 3.5% after 1.5 year follow-up. And for the perinodal AVRT, the recurrence rate is around 15%. So we have some modification of the arrhythmia ablation protocol and can increase the success rate and decrease the recurrence rate. However, for perinodal AVRT, the recurrence rate is still not low. There is still some effort we have to do to improve the recurrence rate. Finally, I will talk about the high density mapping and the contact force catheter. These are both for the complex arrhythmia in congenital heart disease. In the current guideline, the treatment of the arrhythmia in adult congenital heart disease include the medical control and the catheter ablation. Although medical control shows some benefit, however, the long-term effect is still not very good, and the long-term complication for the medical control is still a concern. So catheter ablation is generally preferred over long-term anti-arrhythmia medication in the current guideline, especially for the SVT, IRT, and the less complex congenital heart disease. In our previous experience, we have shown the 3D mapping system can improve the success rate significantly. However, in the past, we use the ablation catheter to perform the 3D mapping, and we have to perform a dot method to create a geometry to perform the electrical map, and it is very time consuming. For around, we should use around 30 minutes time to perform around 500 dot map for the 3D mapping. And now we have a more powerful tool. Using this ultra high density mapping catheter, we can receive around 16 points within move of this catheter, and we can collect around 6,000 dots within 3 minutes, and we can see this is a complex congenital heart disease, and we have DORV and VT, and we perform the RVOT, the right ventricle mapping, and we can see within 3 minutes, we have more than 6,000 dots correction of the geometry and also the electrical map. Because the arrhythmia in congenital heart disease is very complex and the multiple arrhythmia is very common, and also they are always not the usual circuit of the arrhythmia substrate. So in this situation, ultra high density mapping is very necessary. And we can see in this repair tetralogy of our patients who have multiple arrhythmia, we use this ultra high density mapping system, and we can see we have collected around 20,000 dots within 10 minutes, and we can see this unusual circuit of the re-entry circuit. Then we can see another new technology is contact force. Although we can have a good mapping use the 3D mapping system, if we have a good contact and the energy can go to the substrate very effectively, we didn't know. So a new catheter is called a contact force catheter. It has some sensor in the tip of the catheter, so it will tell us if we have good contact with the endocardial surface, and let us know if the ablation is effective or not. Not only it will tell us how wet is the catheter contact, it will also calculate the so-called lesion size index or the time curve or the time force integral, and to let us know if this lesion is ablated effectively or not. So with this new technology, we can shorten our ablation time with a higher power. So it is so-called high power short duration ablation. It is more commonly used in the atrial fibrillation ablation. With this new technology, we can shorten our procedure time, shorten the follow time, and shorten the irrigated fluid use. However, with shorter duration, there is higher frequency of the acute pulmonary vein reconnection in the ablation of pulmonary vein isolation. However, the long-term outcome shows less recurrence. So in this method, it is more time saving and also can have lower recurrence. It's used in congenital heart disease. The experience is now is still rare. And this is a report in 2016. We can see use this contact force catheter. The success rate is similar to the previous one, and but the follow-scopic time can decrease dramatically. We have also some cases using this new technology in a patient of the AD with atrial flutter and also atrial fibrillation. We perform the PVI using this contact force catheter, and we can know each point is effective with the contact force should be more than 10 gram, and the lesion size index should be more than 5. And we can make sure that every dot is effective. And also we use this contact force catheter to perform the carbotrichotomy isthmus ablation. And sometimes for congenital heart disease, the carbotrichotomy isthmus is thickened, and it is sometimes difficult to ablate with some leak, especially for those who have previous tricuspid surgery. Using this method, we can make sure the contact is good and the ablation is effective. So I will make a brief conclusion here. There are many new technology advanced in recent years, and it is all can improve our efficacy and improve our safety. The non-fluoroscopic mapping is feasible and can be routinely used for pediatric ablation now. For the QUEK ablation, it is requisite for high-risk patients in pediatric. And also the high-density mapping system and the contact force catheter can improve the efficacy and also improve the shorten our ablation duration, and also our mapping time in the complex congenital heart disease. And it is a very useful tool. So here I have to promote our APPCA 2021, and it will be online in a virtual congress in July 17 and 18. And it is a virtual meeting. So I hope everybody can register, and the course is completely free. So see you in the APPCS 2021. Thank you.
Thank you, Professor Chu. And now we have a lot of new weapons. The same, we'll leave all the questions to after the third talk. And before I turn my podium to my co-chair, Professor Bei, I would like to introduce Professor Bei. And Professor Jung Bei is Professor of Pediatrics in Seoul National University Hospital and Seoul in the National University Children's Hospital. And she is currently president of Korean Heart Rhythm Society. May I turn my podium to you, Professor Bei?
Yeah. Good morning, everybody. Thank you, Organizing Committee and Professor Wu for preparing this wonderful APSC crowd conference. Yes, I work as a co-chair. I'd like to introduce the third speaker. We invited Dr. Swee QUEK. He is a consultant in Department of Pediatrics and Adolescent Medicine, Hong Kong Children's Hospital. And he also a council member of Hong Kong Inter-Hospital Network for Pacing and Cardiac Electrophysiology. Okay, he will give us a talk about left bundle pacing in pediatrics. Please welcome Dr. QUEK.
Okay, good morning, everyone. It is my honor to be invited to participate in this wonderful webinar. And one good things from Hong Kong, I'm SY QUEK, have been introduced by Professor Bei. And our cardiology unit in Queen Hospital previously have successfully translocated to the new Hong Kong Children's Hospital the end of last year. So it's my pleasure here and to deliver a talk on this fantastic technology in pediatrics. So let me share my screen first. Okay, I hope everyone can see my screen now. And in the past, it was grateful that our department have great room for us to try different cutting edge treatment in the past, including cryoablation, non-fluoroscopic 3D mapping, SICD, etc. So today I'm going to talk about this state-of-the-art pacing technique, which is now widely practiced in and adopted in adult patients. Hope going through this talk, we all have some discussion on it, whether it could be applicable to our pediatric patients. So I first start to share, I have nothing to disclose, okay? And let me share this case first. And I saw him last week. He is now a 13-year-old with a congenital complete heart block. He leads epicardial pacing system with the right atrial and right ventricular lead implanted right after birth. Unfortunately, the system needs to be upgraded to the CRTP because of the development of heart failure at 3 months. Echocardiogram suggestive of RV pacing induced dysynchrony. So we have upgraded him to the CRTP therapy, and the CRT had helped him to tide over the heart failure period. Generator was replaced at 7 years of age. At that time, because we find on echo, actually the echo performance is better on the LV pacing only. So we switched to LV pacing only. But he developed syncope 2 years later, and we find a fracture of the epicardial system, which is quite not very common, but it's not surprising in our pediatric patients. And then we need to change back to the RV pacing for these kids. So we worry about the recurrence of the RV pacing induced dysynchrony and heart failure. But luckily there's no heart failure symptoms. But the ECG still show, as you have seen, that it's still the RV pacing rhythm with a YQS duration, also with that dysynchrony. We are not sure about the long-term prognosis for this kid, especially now as the battery reached the elective replacement index. So what will you offer in your clinic? Will you change the abdominal generator only, or you will ask the surgeon to implant another epicardial LV lead? Bear in mind that it would be deemed difficult for the re-entry and also difficult to find a new lead pacing for the epicardial LV surface. So how about implantation of a new transvenous system? maybe we need to implant a new CS lead, but it would be very difficult for us as a pediatric practitioner to put in a CS lead as well. So now we have something. Is there something we can newly offer for this kit? So this is the concept that is newly being advocated, which is called the physiological pacing. It's the direct pacing of the His-Purkinje conduction system. So the originally favored site of the conduction system pacing is the His bundle. So just let you know the His bundle anatomy, it consists of two parts. One is the penetrating His bundle, the other is the branching His bundle. Actually, as you can see from this diagram, the branching is not the real one. Actually, before the begins of the right bundle branch, actually there's already a fencing of the left bundle branch. And so you can see there's a quite large area of the left bundle branch in which the left bundle branch pacing can be targeted on. And after fencing, there's the left bundle branch travels along the subepithelial surface of the LV. So there's already many studies talking about the physiological pacing in adults. They have incorporated into the guidelines in if the adults having LV function borderline and predicted to have a high percentage of pacing, it is a class 2 indication to consider physiological pacing. And already there's also data to suggest the His bundle pacing or the physiological pacing is better in terms of the mobility and mobility in long runs in the adult patients. Despite this fantastic concept, however, His bundle pacing have not been widely adopted due to its limitation. As I mentioned, it is difficult to find a precise location for the His bundle. And also because of the encapsulated layer of the His bundle, it used to have a higher capture threshold and also poor sensing. So during the implantation, there's also a possibility of damage to the His bundle. And also theoretically, if the heart block site is distal to the pacing site, it also failed to use this His bundle pacing to tackle the problem. So the Hwan group in 2017 have published their first case to introduce the idea of left bundle pacing. So they advocate because the left bundle branch pacing is having a wider target as illustrated in this diagram. And also because it's pacing more distally, it could tackle those pacing problem beyond the site of the His. And also it's enjoyed a low and stable threshold, good sensing, and also high stability. And for the lead size, because the Medtronic one is smaller, so it may be conferred a better advantage for our pediatric kids as well. So there's a study already shown the His bundle pacing and the left bundle pacing comparison. If you can see that left bundle pacing, bundle branch pacing have a less procedural time, less fluoroscopic duration, a better capture threshold, and a better sensing. The Pandala group have published a good systemic review already. There's a 10 paper there, cover about 500 patients. The duration of follow-up is just 6.7 because it's the latest technology, but it's already pinpointed the success rate is up to 80 to 90%. And also there's a few complications only. Bear in mind that there's still some late complication in 2 months and 4 months with the lead distortion. And the Hwan group, this is a very important paper and just published last month and talking about the initial experience in intermediate follow-up and by Wanzhou group. And this is the group that I've mentioned. They do the first left bundle branch pacing. They follow up at 18 months and their group have achieved a success rate of 97.8%. And also they have a good pacing parameters, also echocardiogram show better function and few complication rate. So it is a fantastic technology and the group have shown that, although we are still waiting for a longer term result. So how to perform left bundle branch pacing? Actually, there's many reviews have a good description of how to perform this. You can always refer to them. But the most important is the setup. And for them, you need to have the patients to be hooked on the 12 lead ECG. And the pacemaker programming and programmer need to be connected to the EP recording system by jumper cable. And here is the weapons. And first is the select secure 3X30 pacing lead. And this is a 4.1 French lead with the luminous design. And also need to be coupled with the long shift. This is a special design shift C315 heat shift with an outer diameter 7 French. And of course, the other alternative, which a bigger diameter, is 8.4 French C304 deflectable shift that you can use with the Medtronic system. The other system that you can use is the Biotronic one, which have a more firm delivery shift catheter, and also with the advantage it is select driven. So the select can guide the catheter towards the size that you want to go. Of course, for the two legs, the profile is almost similar, and the length is the similar of the helix and also the ring and the capture electron. Though the lead for the Biotronic one is a little bit larger size. So the first step of the procedure would be the identification of the hits. In children, I think an RV angiogram is very helpful to identify the septal area and the potential approaching site. And the whole system is first rotated clockwise and to across the tricuspid valve. And then we use the counterclockwise torque to apply to bring the long shift towards the septum. So in the RAO view, you can use this view to advance the lead 1 to 1.5 centimeters along the emerging line towards the apex. And then you turn to the LAO view. And then make sure the lead is positioning perpendicular to the septum. And this is where you would like to apply your screwing of the 3030 lead. And there's a paper advocate this line segment approach. It divided into a region in the RAO view into 9 regions. And they find that the His bundle pacing is the most successful in the region 2. Whereas if you want to target the left bundle branch placing site, you should go for the region 5. So this could give you a rough site of estimation where the shift and also the lead should go. So next step is that you look at the ECG and then you ask to pace at the region of interest. First of all, you identify a W sign in the V1. This is the region that you want to target on. And also you will show a discordant of the AVR and AVL. This is the site you want to screw your lead in. And of course, you can pace at this site to see how the appearance, and then you start to screw your 3830 lead into. And some tricks in screwing the lead is that you need to ask your assistant to hold the shift for you. And then you ask him to maintain the anti-clockwise torque. And then you use your two-hand technique to ensure your hands are close to the shift and the lead insertion site so that you can firmly apply the torque and to screw the lead in. And during the screwing, you will see the R wave changes from the initial W pattern and you can see the lodge is moving, migrating backwards. That means that there's a late activation of the right bundle branch. And then, unlike an adult, most of the pediatric implanter would advise to have a low threshold to stopping the screw in because we worry about the perforation to the other side into the LV. So after you see the change in the pattern, you observe the left bundle potential in the EGM. When you pace it, you'll find that the pacing to the LV peak, that means the LV activation time is short. It's usually 70 milliseconds, and also a relatively narrow QS complex that you should be at the left bundle. So after which you can inject the contrast to profile the septum and also to see the depth of the implantation. At the same time, for pediatric patient, I will ask for the TE assessment as well, because it can assure that we have an adequate depth into the septum and there's no septal perforation. And then you withdraw the shift, and then this is the fulcrum sign that you can also ascertain the lead and also the ring and also electrons are all within the septum. So this is our first case of employing this technique in a 21-year-old with congenital heart block. And you can see they have good sensing, good pacing threshold, good impedance. And also if the better echo performance after doing the left bundle placing, and you can appreciate the narrow QS duration compared to the old ROV pacing. So this is the echo appearance. You can see from the ROV old backup system, we turn on the ERI, the old pacemaker. You use the ROV pacing, you can see there's a still septal flashing and also septal impairment in the function. But overall, after the left bundle branch pacing, the performance is much better. So how about our small kids? Is it applicable to our pediatric patients? So nowadays, only isolated case reports or small case series for pediatric patients have been published to show the successfulness of this technique in small kids. The youngest one being published in a 6-year-old, 18.5 kilogram, and the thickness of the septum is only 7 millimeter. And of course, for congenital heart ablation, the technique is challenging because of the abnormal position of the His bundle. You can see different types of congenital heart conditions with different types of the AV loop positions. So in the PACES, our international pediatric congenital heart group, they have published a paper concerning 15 congenital corrected TGA patients. And because of the difficulty of identifying the His patient, they use the 3D mapping to first identify the His Purkinje system first. So I think this is would be very helpful and to identify the location of the left bundle branch. So for the left bundle pacing, they use the H grid as well for the high density mapping over this area. Finally, I would like to share a case which I performed for a 4-year-old. And I want to show you the challenges of applying these techniques to the young kids. This case is just 13 kilogram. And as you can see that already it's a very small skid and the small position after hooking up the child, it's just a small area for us to create a pocket. And then on the TEE, so the thickness of the septum is just around 5 to 6 millimeters. Compared the lead, you can see the tip to the ring is 9 millimeter. And first, we use the CRD catheter to position the His position. And as you can see, we use the standard C3150 sheath. But you can appreciate it's very difficult for us to use this sheath because relatively large size of the sheath in a small kid. It's difficult to align very perpendicular to the septum. Now, however, we finally were successfully find a site, we screw in, and we achieve a really wonderful ECG of left bundle branch pacing. But however, when we do the angiogram, we find that actually the screw is a little bit deep in. So we're a little bit worried, though the TE did not show the perforation of the lead into the LV and it's within the septum, but we decided to withdraw the lead and retry again. So this time we have a better position with a more perpendicular to the septum, 5.2 mm into the septum. Also, as you can see, we achieve a good result of pacing, capture threshold, sensing, no drop in impedance. And on the TEE, you can see that we quite confident that the lead is within the septum already. And there's some ROV tissue here because of the first withdrawal of the catheter, pulling out some ROV tissue here. But we think that we are satisfactory on placing the left bundle branch lead. However, the life is not easy. And when we are about to fix the lead was found to dislodge while withdrawing the sheath. And so we have tried 2 more times. And also with a good parameters, we appear the septum is not thick enough to hold the lead as well. So we decided we not go for the left bundle branch pacing. We implant our standard BVI pacing with ROV pacing lead. Echocardiogram is not suggestive already residual left to right shunting, and it's also the tissue mass gone away without any complication the next day echo review. And I shared this challenging case to show the limitation of this technique to our small kids. And there's still many things that we do not know about the left bundle branch pacing in pediatrics, including we are still waiting for the more prospective registries to come. And of course, we worry about the LV perforation, as previously mentioned, and we used to leave some slack in pediatric implant, but if there's too much slack, there will be increase in the risk of the LV perforation. And also for this technique, multiple attempts can cause local tissue damage, right bundle branch injury, and also potential injury of septal artery as illustrated here. And there's a worry about the lead distortion after implantation. We are still waiting for more long-term data on the capsular vessel and also safety of techniques of lead extraction. There's one case of successful lead extraction, but we are not knowing about the long-term, if the lead was there for many, many years, if there's a possibility of extract these leads. And of course, I've mentioned the leads likely to be further investigation in pediatric implants. And this is the case report of the late onset interventricular septal perforation for the left bundle branch pacing. So I hope with this short 15 minutes, I'll go over and convince you that the left bundle branch pacing is feasible in older kids. And there's a lot of advantage over the hip bundle pacing and right ventricular pacing. Of course, there's still limitation in young kids, especially the septal thickness will hinder the stability of the lead and also to perforation risk of the lead. And there's no tailor-made shift for our pediatric patient. There's no long-term data. And also for the position of the hip bundle or left bundle branch fork will be difficult for a congenital heart patient. And I'm grateful that I have a great EP team that can share the challenges, and also I have all sorts of great support from all the different experts. And this is our new children's hospital to have a visit after the COVID pandemics to Hong Kong, and stay healthy, everyone. Thank you for invitation. And I invite any questions and also comments.
Thank you very much, Dr. Kwok. You gave us a wonderful talk on this new and challenging issues on left bundle branch pacing. And because of time limitation, I'd like to move on the next issues. Yeah. Okay. Next speaker is Dr. Daiji Takeuchi. He is working for the Department of Pediatric and Adult Congenital Cardiology, Tokyo Women's Medical University, Tokyo, Japan. Please welcome Dr. Takeuchi. Dr. Please.
Okay. Can you see my slide?
Yes, we can see you.
Okay. I'd like to thank APSC and the chairman of inviting me to this meeting. Today's my topic is atrial fibrillation in adult CSD. Slide showing increasing prevalence of atrial fibrillation for short AF in adult CSD. Data from U.S. multi-center cohort study, including 482 CSD patients with atrial arrhythmia. Most common arrhythmia is IALT, 61% per percent, following AF 29%, focal atrial tachycardia 10%. IALT is common age and 50 years old, and on the other, AF increased with age. In age over 50 years, AF proportion exceeds IALT, and 40% is AF. The onset time of atrial arrhythmia differs depending on CSD. Atrial arrhythmia is more likely to occur in complex CSD, such as TCA, univentricular heart, and tetralogy follow, other than simple CSD, such as ASD. The risk of atrial arrhythmia is high in complex CSD. It usually occurs with AT, and the AF increases with age. On the other, simple CSD, such as ASD, the risk of tachycardia is low. The onset time is late, and AF often begins as initial tachycardia. Regular AT coexistence with AF in nearly 30% patients, and rapid progression in AF in CSD has been reported. 26 of patient deterioration of proximal to persistent permanent AF during mean 3 years follow-up. In tetralogy follow, rapid progression AF in 38% within 5 years of onset. Permanent AF increase as age, 3% in age and 20 years to 23% in age over 50 years. Atrial arrhythmia in CSD changing in time and patterns with age, especially on complex CSD. The first AT usually occurs at young age. AT triggers proximal AF and highly coexistent with AF. Proximal ATF is easy to progress to persistent permanent ATF. If related to various adverse events, our cause of death is 5 times higher than CSD without AF. 2 to 3 increased adverse events, including stroke, heart failure, hospital admission, and cardiac intervention. High risk of heart failure, sudden death, and stroke. Therefore, early detection of AF and intervention is important to reduce adverse events in CSD. Non-CHD patients with AF, pathophysiology of AF is associated with left atrium, represented by pulmonary pains. On the other, in CSD, many CHD, such as Epstein anomaly, postpartum ablation, tetralogy follow, have large right atrium, pochette RA, and atrial incision led to arrhythmogenic substrate in RA. Most of ILT focal AT can be treated by RA ablation. Also, arrhythmic substrate in right atrium seems to play an important role in occurrence and maintenance of AF in CSD. The mechanism of AF and the role of left atrium in CSD are still unknown. Atrial fibrosis is an important tissue change that plays a major role in development of atrial arrhythmias. RA tissue from 65 patients with RA volume overload with SVT episode showed strong fibrosis compared to control and the non-SVT groups. This is our unpublished data. We studied the degree of atrial fibrosis of RA from patients who underwent Fontan conversion. Nearly 50 and 30% patients long after Fontan surgery already had moderate and severe atrial fibrosis. Persistent permanent AF group showed stronger atrial fibrosis than no AT and proximal AT group. This is a case report from my institute. Fontan patient showed AF with large RA and widely spread low voltage area. Multiple ablation targeting fractionated potential gradually stabilize the tachycardia cycle length and eventually terminate atrial arrhythmia, AF. And it's true that AF can sometimes be treated with ablation of arrhythmogenic right atrium only in CSD. However, for patients who plan Fontan conversion with a history of AF, it's recommended to add COX-3 to left atrium with RA missed at Fontan conversion as class 1 indication because it's known additional COX-3 missed of left atrium lowers the post-operative AF recurrence rate. This suggests in CSD with RA enlargement and late atrial incision, also the right atrium play a major role in arrhythmic substrate and arrhythmia maintenance. Filing from PV on the left atrium side may trigger complex atrial tachycardia. When considering the treatment of AF, it's important to rule out hemodynamic problems such as valve regurgitation, obstructive lesion, ischemia, and ventricular dysfunction. If they are treatable, surgical intervention are also considered. Arrhythmia surgery is recommended if surgical intervention required. Pharmacological therapy, including anticoagulation to prevent thrombus and antiarrhythmic agent. For most of CSD with AF, antiarrhythmic agent is still first-line therapy. We usually use amiodarone for complex CSD with AF, but extra cardiac side effects such as the pulmonary toxicity and thyroid dysfunction and problem. If pacing device is needed for blood culture, atrial anti-tachycardia pacing device is also useful. Also, catheter ablation, pulmonary vein isolation for short PVI is established treatment for AF in non-CSD population. Effects of cardiac ablation for CSD is not established yet. Knowing the effects of AF ablation, especially PVI on CSD, is important in considering the mechanism of AF. So I'd like to explain AF ablation in CSD. This is a multi-center registry study from US about AF ablation. 84 CSD patients, including 39% complex CSD. PVA performed 95% with RA side ablation 47%. PVA alone is only 36%. Also 1 year complete and complete partial freedom, 53 and 71% seems slightly low. Major complication is 0. It's good results. Another report from Columbia University Medical Center performed AF ablation for 56 CSD patients, including 39 complex CSD. They performed mitral isthmus ablation 42%, LA roof line 40% higher rate, and cardiothoracic speech isthmus ablation in RA 70% in addition to PVI at first session. They say also freedom of AF after first session is low. 1 year 63%, 5 years 22%. That after multiple procedures is significantly improved. 1 year 99%, 5 years 83%. This is our case, 52 years old man with DOLB after lateral procedure and AF and multiple AT. He had been undergone RA side ablation and the PVI already. After lead PVI combined with fractionated potential ablation in RA at third session, he finally achieved freedom from AF recurrence. This is our results from about AF ablation for complex CSD only from 3 centers. Event-free rate after initial PVI procedure with any RA side ablation in 45% is low, but it's improved after multiple procedures, including lead PVI and additional RA ablation. For complex CSD, simple PVI alone is not sufficient, suggesting non-PVI triggers and RA ablation are also required for AF control. According to PACE's expert consensus 2014, PVI isolation can be useful in adult CSD and symptomatic drug refractory AF as class 2A indication. Now, AF ablation in CSD is class 2A indication for drug refractory AF. By convention, antiarrhythmic agents such as amiodarone are still the first choice for AF in complex CSD. However, increasing evidence of efficacy and the safety of AF ablation for CSD may change the indication and the strategy of AF ablation for CSD in the future. This slide shows the summary. Thank you for your attention.
Okay. You closed your session. Thank you very much. You give us a very comprehensive review of very important issue and we faced the increasing population of atrial fibrillation in adult congenital disease. And you also showed the effectiveness of right side ATR cafe ablation in addition to coronary vein isolation. Thank you very much. And because of time limitation, we will discuss, we will have question and discussion at the end of the entire presentation. And so all the speakers, please keep online at the end of the presentation. The final speaker is Dr. Chun. He is working for the Adult Congenital Heart Center, National Taiwan University Children's Hospital. He is an assistant professor of pediatrics of National Taiwan University College of Medicine. He will give us a talk about the new concept of anticoagulant in pediatric arrhythmias. Are you ready? Dr. Blue? Okay, yeah, please.
Yeah, I'll talk about the, can we use NOAC for stroke prevention? Today, I will discuss can we use NOAC for stroke prevention in adult CHD with atrial arrhythmia. Just as Dr. Takeuchi told about the atrial fibrillation, the atrial arrhythmia is very common in adult with CHD, including intra-atrial re-entry tachycardia, focal atrial tachycardia, and atrial fibrillation. And these three arrhythmia can increase with age, and those with atrial arrhythmia have higher risk of stroke compared with HCC without atrial arrhythmias. And when the patient become older, they tend to have more atrial fibrillation or more permanent atrial arrhythmia, especially for those with some comorbidity, such as higher BMI, hyperlipidemia, and hypertension. The thromboembolic event in CHD with atrial arrhythmia is very high, and the most important independent risk factor is the CHD complexity. If you have the more severe complex heart disease, there is no more chance to have thromboembolic event. But the type of atrial arrhythmia is not don't have the predict risk of the thromboembolic event. For general patient with atrial fibrillation, the ESC guidelines in 2020 suggest considering the risk factors for stroke to decide when to use the anticoagulation. Like the Chye score is usually considered in such patients. if you have score equal to 1 in male and score equal to 2 in female, you will consider using the oral anticoagulator for prevention of stroke. But if you have higher score, it's more evident recommendation to use the long-term oral anticoagulation. Now, how about the chest VAS score in HCHD with atrial arrhythmia? The two studies, one is the study from Netherlands, and another study from Japan, also showed higher thromboembolic event in higher chest VAS score. So in HCHD population with atrial arrhythmia, the chest VAS score is also can be used to guide the anticoagulant using. Convention oral anticoagulant, we tend to use vitamin K antagonists. It is inhibitor of factor 2, 5, 9, and 10 through the vitamin K effect. It can be used by oral route, and it can reverse by vitamin K or prothrombin complex concentrate when major bleeding occurs, but it possesses some shortcomings, such as slow onset and offset, narrow therapeutic index, require regular monitor with PT or INR. It's those depend on age or comorbidity, and then most importantly, they have many diet and drug interaction, and the drug is mainly by hepatic clearance. Now we have new anticoagulant as NOAC, novel vitamin K antagonist oral anticoagulant, or it can also be called direct oral anticoagulants. There are two groups of NOAC. First is factor 10A inhibitor, such as rivaroxaban, episaban, and edoxaban. They inhibit the factor 10A directly without the need for antithrombin activity. And another group of drugs is direct thrombin inhibitor. There's only one oral form called dabigatran. It can direct inhibit the thrombin. The new NOAC can compared to traditional VKA possess very many benefits, such as quick achieve pharmacologic effect and reduce dietary and medication interaction. It tends to have longer half-life, no need for substrates such as antithrombin or vitamin K. It has a stable viability and pharmacodynamics, and a wider therapeutic window compared to VKA, and less need for monitoring. But we have to pay attention that this drug needs dose adjustment in renal impairment. Generally, the NOAC is approved for VTE in joint replacement and prevent arterial TE in patients with atrial fibrillation, and treat of deep vein thrombosis and pulmonary embolism. First, we will talk about the factor 10A inhibitor. The rivaroxaban is once daily. It has good bioavailability, and it can also prevent acute coronary syndrome at a high rate of, but this drug has a high rate of heavy menstruation. The second drug is episaban. The drug has less GI bleeding than rivaroxaban, and need twice daily. The third drug is edoxaban. It has longer half-life and good availability, and you need once daily. Another group of DOAC is the thrombin inhibitor, the dabigatran. It was the only drug with FDA-approved reversal agent among the DOACs. From this table, we can see the different DOAC has different half-life and the different proportion of excretion by the kidney. For adult patients with CHD, there are other indications for anticoagulation besides atrial arrhythmia, such as spontaneous circulation and the previous history of stroke or right to left shunt or pregnancy or bowel processes. So if the use of anticoagulation in adult CHD is often more complicated. We have several concerns for the NOAC use in adult CHD. First, now NOAC is considered contraindication in mechanical heart valve. It's because the dabigatran trial in Reliance study, they found excess thrombotic and bleeding event in mechanical heart valve. So the study is halted early. It is because the mechanical heart valve may induce thrombin generation to overcome the effect of dabigatran. But there is no evidence that factor 10A inhibitor can also cause similar situation. But for now, the guidelines suggest in patients with mechanical heart valve, the NOAC is contraindicated. Then how about the bioprosthetic heart valve? Because the bioprosthetic valve also had diaphragm sewing ring, it can also promote thrombin generation and inhibit the effect of thrombin dabigatran. So now VKA is suggested in patients receive bioprosthetic valve after during the 3 months period for rings undergo endothelialization and avoid the use of the NOAC. And another contraindication is for patients with severe mitral stenosis with atrial fibrillation. And actually, there is no evidence, no head-to-head comparison between VKA and NOAC in MS patient with atrial fibrillation. The contraindication simply because MS patients were excluded from all trials. But there is a very interesting paper published recently in Korea, from Korea. They used health insurance review database. They found there are about 1,900 patients with mitral stenosis use anticoagulation in this database. And they compare with patients with VKA using propensity score metric. And interesting, they found the patient using NOAC, they have much significant less stroke and significant all-cause mortality, and similar in intracranial bleeding. So this observational study may open a window for a future clinical trial of mitral stenosis in atrial fibrillation patients by using NOAC. There are several other concern about NOAC use in HSD. For patients with underweight patients, they have much more risk for major bleeding. And all NOAC should be dose adjustment in patients with renal impairment. And the rivaroxaban is suggested to not use in patients with liver dysfunction, which is common in Fontaine patients. And we should avoid all NOAC in patients with advanced liver cirrhosis. And NOAC is contraindication during pregnancy and breastfeeding. And the factor 10A inhibitor, they may cause heavy menstruation. The incidence is about 1/3. And the rivaroxaban is associated in prolonged menstrual bleeding. That's we have to notice that. But NOAC with some benefit, because brain has high level of tissue factor, they can overcome the effect of NOAC. So NOAC, the use of NOAC may decrease the chance of intracranial hemorrhage. For patients with a risk of bleeding, such as hypertension, abnormal renal functions, history of block, and they have greater Hess-Flash score, may have more risk of bleeding using anticoagulants. And although the drug interaction for NOAC with other drugs is less than VKA, but there are some potential medications such as rifampin and other anti-epileptic drugs can also interfere with NOAC. How about NOAC used in HSD? There is a NOTE trial including 35 centers in 10 countries. They found that about 530 patients with NOAC, most of them have atrial arrhythmia, and half of them with severe heart disease. The short-term effect looks promising. There is not much thromboembolic event or major bleeding after short-term using of NOAC. And compared to previous use of VKA, there's similar thromboembolic effect and the similar major bleeding incidence. So as per consensus of arrhythmia in ACHD, they suggest for moderate and complex CHD, they suggest using VKA instead of NOAC. But for simple HSD without a mechanical valve or significant valve disease, if they have risk factor for stroke, they can consider VKA or NOAC. Finally, I will talk about an interesting study. This is also insurance data from Germany. We can see that the adult CSD patient had increasing using of anticoagulation with years. And since the introduction of NOAC, they are used more frequently than VKA. But after the comparison of the outcome in patients using NOAC or VKA, they found VKA are better in many aspects, such as all-cause mortality, major advanced cardiovascular events, and major bleeding. VKA shows better results than NOAC. So finally, when we use NOAC in HGSD patient, we have to be aware of that there is some contraindications such as mechanical heart valve or severe valvular disease, and the recent cardiac surgery within 3 months. The patient intend to be pregnant or during pregnancy. NOAC can be considered in atrial arrhythmia with simple valvular CSD with stroke risk factor. And for complex CSD with atrial arrhythmia, now suggest using VKA instead of NOAC, but large-scale study required for head-to-head comparison for HSD patient subgroups. Thank you for your attention.
Thank you very much, Dr. Wu. You gave us a very comprehensive review on the anticoagulation issues in adult congenital disease populations, and you also showed the possible role of NOAC in the field of congenital disease. And thank you very much. And we have almost 10 minutes left, and we have a question and discussion time. And everybody online, any questions?
So I have a question for Dr.
Yes.
Wu about left bundle pacing in pediatrics. And as we know, the left bundle pacing is better, maybe better than the DGD pacemaker pacing because of may cause less dysynchrony. But the choice of a patient is how do you know our insertion site is proximal to a QUEK, the bundle branch QUEK, or distal to a bundle branch QUEK? Will you perform the BP mapping, that 3D mapping first or not? And maybe for the surgical AV block, it is we're understanding because the surgical AV block it is more at the proximal part. But for the continuous AV block, or in some cases, maybe the VT ablation and cause the bundle branch block. How do you know your patient side is distal to the block side?
Okay, thanks for your question. It's difficult. I don't think because anyway, I think personally I will choose left bundle branch pacing rather than the his bundle pacing. So anyway, if the left bundle branch pacing is not going to, to correct the left bundle or the left bundle disease already, so is already proven it will not work for the his bundle pacing. So I think we just don't go directly for the left bundle branch pacing without any mapping would be the approach. And unless you really you have a preferred approach of the his bundle pacing first, then you are going to map the left bundle. Like I've shared one screen that you can use the 3D mapping to really map that. But because of the procedural time and also is complicated, I think we will just go for the left bundle branch pacing. If really, I think nowadays we just prophylactically, if the baseline ECG did not show the left bundle branch block and the function is normal, then it's not really an absolute indication to do the physiological pacing now according to guideline. But I think most of the people now will go for, if we can do it, then theoretically in the long term it will benefit the patient. So we need more long-term data to apply this technique universally. So no guidelines will support us to do it anyway. Yeah.
Okay. I have a question, Dr. QUEK, and about the left bundle branch pacing and about the safety issues, because we should introduce left bundle pacing data more deeper in the transventricular septum. Okay, so that make more myocardial injury or coronary artery septal branch injury, etc., especially in the pediatric, possibly pediatric age group. How do you think about it? Or later, ventricular tachycardia around the lead inserted interventricular septal myocardium. So how do you think about it?
I think I still don't have the data to support either way, because I think your concern is valid. So I also will need to very detailedly discuss with the benefit versus the risk. I have actually, one of the paper is my friend quoted by China. They have performed, actually the youngest kids they have performed is 14 kilograms, and they also they don't have any complication for this kid. And also I think more data will be coming to support the use of this technique in very young kid. And but I think there's still a threshold. I mean, even very young kid, I still have some concern. So if really feel difficulty of implantation, and I will not go. I will not insist on the procedures, and we just go for the conventional one. But I think all the precautions need to be very well taken, especially, for example, use the TE as a guidance, and also to at least feel for the to have a better preparation, and also have a good discussion with the parents if you really want to contemplate these very new procedures to the pediatric patients. Yeah.
Okay. Another questions or?
I have one question for Dr. Takeuchi about the atrial fibrillation operation in congenital heart disease. And we know the atrial fibrillation operation in congenital heart disease is very difficult, and we don't know the actual arrhythmia mechanism, and we now use the pulmonary vein isolation and also sometimes cafe operation in most of the center. How if the patient receive pulmonary vein isolation and so some cafe operation, but the atrial fibrillation persists, will you perform the CS isolation, atrial appendage isolation, or SVC isolation in these difficult cases? How do we suggest?
But basically, our goal is PV isolation, and it is our goal. And additional cafe on the roof ablation of airway is there's no evidence of to suppress the AF. And so basically PV isolation complete, and is a first or second session our goal. And especially ablation we also do if a patient has no sick sinus syndrome. And in complex CSD, if a patient has a fracture or AT, so we also do the CTI ablation, and we obtain the voltage map of array. And if we need more array side ablation, for example, incision lesion, or after CTI ablation and the PVI, and we also induce the array atrial tachycardia. If atrial tachycardia induced, we remap the tachycardia, and so we decided to more ablation or required or not.
Thank you.
Thank you. Is there any question or comment on the presentations? I'd like to ask about the KWOK preparations in the adult congenital disease preparations. In our hospital, for the Fontaine operations, we prescribed warfarin preferentially. So Dr. Liu showed some paper on the experience about the KWOK on the complex congenital disease, including content patient. So in your hospital, do you use warfarin or QUEK?
Yeah,
in
our
content patient.
Because our insurance regulation for NOAC is very strict, because the NOAC is relatively expensive. So for Fontaine patient, we major use VKA, and currently there is no strong evidence that NOAC is better than VKA or compared with VKA. So the Fontaine patient, we use mainly VKA, or some with low risk, we use aspirin in such patients.
Okay, can I ask you another question? Is that for a simple congenital heart patient, now maybe it's complex, maybe repair TOF, then it's in the middle, then biventricular is well repaired, the systolic function is very well, and maybe the gentleman have the persistent maybe atrial flutter, and Chaffer score is just 1. Will you contemplate anticoagulation or long-term anticoagulation for this gentleman or not? Because you know that some adult physician will think that it is structural heart, but you know that all along they mention about structural heart is a left-sided disease rather than a right-sided disease. So I still do not have a very strict answer whether we should advocate the anticoagulation or not. But do you have any preference or any comments on this?
Yes, of course, there is no strong evidence to suggest use of anticoagulation in such patients. But I tend to use anticoagulation for those with risk score or more than 1 or equal to 1, with chronic or paroxysmal atrial fibrillation. For patient with tetraflow with wheel function, I will consider use of NOAC in such patient. Actually, I have several patients are using the NOAC in such situation. Just as I told, there is no strong evidence against the use of NOAC in valvular disease, but we have to be aware about the Germany study. The NOAC may be have lower prevention for the stroke and the higher mortality rate compared to the VKA, although it is much more convenience during the usage.
Okay. Do you have any other question or comment? Okay. I think it's time to conclude this session. Thank you very much for the speakers and audiences. I believe this conference provided a very meaningful chance to join our knowledge and experiences about in the field of pediatric arrhythmias. And I also hope all the speakers and the audiences and their families in good health in this COVID-19 pandemic years. Thank you very much for the speakers. Thank you.
Thank you.
Thank you.
Bye-bye.
Bye.